Good morning, everybody. The topic for today's presentation is neurological manifestations in HIV. Let us understand the global burden. In 1981, AIDS was first recognized in United States as unusual infections like pneumocystis pneumonia and Kaposi sarcoma. Later in 1984, HIV virus was identified as the causative agent of this AIDS. Later 1985, ELISA test was introduced and therefore we could diagnose a lot of patients. So people living with HIV prevalence is 2.4 million. Adult prevalence is 0.2 to 0.25% of the population. Each year there is 60 to 65,000 infections, contributes to 40,000 deaths in a year. The peak infections and death happened in 1990s. After that, there is significant decline due to antiretroviral therapy, improved awareness, and preventive strategies. The geographical hotspot is sub-Saharan Africa. High-risk population which are at risk of this infection are men who have sex with men, intravenous drug abusers, and sex workers. Coming to HIV structure and classification, it belongs to Retroviridae genus Lentivirus. Its shape is enveloped. It is roughly icosahedral. The envelope clavoproteins surrounding it are GP120, which helps in attachment to the host, and GP41, which helps in membrane fusion. There is an important core protein that is P24. Coming to genome organization, there are structural genes and regulatory genes. The structural genes are GAG, POL, and ENV. GAG or GAG gives rise to core proteins like P24, P17. POL gives rise to enzymes like reverse transcriptase, integrase, and protease. ENV gives to envelope proteins GP120, GP41. Regulatory genes are TAT, REV, NAF, VAF, VPR, VPU. TAT and REV helps in viral replication. NEF helps in immune evasion. VAF, VPR, VPU helps in enhancing infectivity and replication. HIV2 makes the different. HIV2 has a different regulatory gene, that is VPX instead of VPU. Coming to pathogenesis and entry of this HIV virus, it attaches to our cells via CD4 receptor. The GP120 on the virus will attach to CD4 receptors. This process requires co-receptors like CCR5 in case of early infection, whereas CXCR4 in case of later infections. After this attachment, the fusion and entry of the virus into the cell is by GP41. Coming to replication cycle, the viral RNA becomes DNA because of enzyme reverse transcriptase. This DNA enters the nucleus and it gets integrated into the host genome via integrase. Thus, the provirus is within us, and this provirus may remain latent or may undergo active replication. So, active replication produces new virions which can further infect the other cells. Coming to genetic variability, this virus has high mutation rate due to error-prone reverse transcriptase. Thus, uh, due to errors, there is variability seen, which is most seen in ENV gene, which codes for 1GP120. The significance of this high mutation and variability is there will be drug resistance and vaccine preparation difficulty because of this. Coming to natural history, HIV is primarily targeting the CD4 positive T cell, that is T lymphocyte. It requires for entry, as we know, it requires CD4 receptors and co-receptors like CCR5 and CXCR4. Uh, as it attacks CD4 positive T lymphocyte, there is progressive decline in CD4 T cells, causing immunodeficiency. Hence, immunodeficiency risking the patient for apoptotic infections and neoplasms. So let's understand why the neurological disease occurs. The neurological disease in HIV is not just because of immune suppression. We can see that it can happen even in early infection, even when CD4 is not reduced much. The mechanism for this neurological disease is multifactorial and stage dependent. The pathogenesis involved is direct viral injury, immune activation due to virus infection, opportunistic infections, or neoplasms. Coming to staging of HIV infection, initially we have stage 0 where there is just patient has recently got infected and laboratory markers can detect this infection. Stage 1 is when CD4 count starts to decrease but it is definitely more than 500 cells and patient has either mild symptoms or no symptoms. Stage 2 is when CD4 count is between 200 to 500 and patient has mild to moderate immunosuppression. This may develop early in the this patient may develop early opportunistic infections in this case. Stage 3 is the last stage where patient will have acquired immunodeficiency syndrome where CD4 is less than 200 or there is presence of AIDS defining illness. There is severe immunosuppression and high risk of opportunistic infections and malignancies. Coming to acute infection, it lasts 1 to 6 weeks after exposure. There is high viral replication leading to viremia. The spread of this virus happens to lymphoid tissue in the brain within 2 weeks. Patient will present with symptoms like fever, rash, lymphadenopathy, headache, sore throat. Neurological manifestation can be in the form of meningitis, meningoencephalitis, seizure, neuropathy, myelopathy. CSF may show mild elevated proteins and mild pleocytosis. Whereas in chronic phase, which may last 10 years if patient is untreated, there will be ongoing replication despite the latency of this phase. It is a clinically latent phase but not virologically latent. The viral replication keeps happening. Immune system gradually declines and CNS involvement is usually seen. Some patients may go for persistent low-level infection. In these cases also there is CSF protein elevated, immunoglobulins elevated and anti-HIV antibodies can be detected in the CSF. This is the final stage, 8 stage, where CD4 is less than 200. There is major risk of opportunistic infection, neoplasms and severe neurological diseases. Coming to neuro HIV manifestations occurred by CD4 count. In early stage where CD4 is more than 500, immune activation due to infection is common. So there is autoimmune conditions like inflammatory neuropathies like AADP, CADP. Whereas in mild stage when CD4 is 200 to 500, primary HIV effects emerge like HIV encephalitis, HIV associated neurocognitive disorders, and infections like varicella zoster. Whereas in later stage when CD4 is less than 200, patient can have primary neurological disorders, opportunistic infections or neoplasms. Primary neurological disorders like HIV-associated dementia, vacuolar myelopathy, distal sensory polyneuropathy. Opportunistic infections like toxoplasmosis, progressive multifocal leukoencephalopathy, cryptococcal meningitis. Neoplasms like primary CNS lymphoma. Coming to entry of HIV into the brain, how the neuroinvasion happens. This enters via Trojan horse mechanism, that is, infected monocytes carry them, which will cross the blood-brain barrier. The process is facilitated by adhesion molecules like VCAM1 present on endothelium, ICAM1 present on glial cells. Viral protein GP120 enhances this adhesion. So easier migration into infected cells helps in entering the CNS. Coming to cells infected in the CNS, the major target belongs to the monocyte macrophage lineage, that is, blood-derived monocytes, perivascular macrophages, and microglial cells, which are important reservoirs. Rarely astrocyte infection, but not convincingly proved. Coming to viral tropism, the CCR5 strain of this virus, they are macrophage tropic. So they will have preferential entry into the brain, whereas X4 strains, that is CXCR4 variety, have lesser CNS entry because they are less macrophage tropic. Hence, some people who have CCR5 delta 32 mutation heterozygously have reduced risk of HIV encephalopathy. The damage to the neurons is by two indirect mechanisms. The first one is viral protein toxicity. HIV protein released from infected cells, which are GP120, TAT, and NEF. These will have neuronal dysfunction, synaptic damage, and leukocyte recruitment. The second indirect mechanism is immune-mediated neurotoxicity, where activated microglia and macrophages will release the cytokine TNF-alpha interleukin 1, interleukin 6, and interferon alpha. And other neurotransmitters released are nitric oxide, quinolinic acid, eicosanoids. These will lead to excitotoxicity, oxidative stress, and synaptic injury. There is also NMDA receptor mediated injury because these neurotoxins will work via NMDA receptors. There is excitotoxic neuronal injury, calcium influx causing neuronal dysfunction. Despite no direct infection, there will be changes like white matter damage, neuronal loss, synaptic and dendritic injury, which is more prominent than cellular death. We should also remember there is something called reversibility. That is, neurological symptom can improve rapidly after starting antiretroviral therapy. This suggests there is damage is likely functional, that is, synaptic and dendritic injury. It is not due to irreversible neuronal cell death. Coming to role of antiretroviral therapy, it is the cornerstone of the therapy. It uses combination of drugs, 3 to 4 agents from different classes. How it works is essentially by reducing viral load, more than 95% reduction over weeks, increasing the CD4 cell count, decreasing the disease progression, reducing the transmission risk. Impact of antiretroviral therapy on neuro-HIV disease. There is dramatic decline in AIDS-related neurological diseases because of ART. The prevention or delay of HIV-associated dementia, HIV-associated neurocognitive disorders is because of antiretroviral therapy. So we should target a viral load of less than 50 copies per ml over a period of 4 to 6 months. Starting ART in all HIV patients ASAP after the diagnosis is essential. If there is opportunistic infection when patient is diagnosed HIV, then you should delay the starting of antiretroviral therapy by 2 to 3 weeks. Because here you have to treat the infection first. Because patient may go for complication like immune reconstitution inflammatory syndrome. Exception for not for starting ART even when they have opportunistic infection is severe immunosuppression like copies less than 50 CD4 positive T cells per microliter, where you cannot wait for opportunistic infection to reduce. You should also know few things like ART is not curative. HIV persists due to latent reservoirs. Drug resistance, long-term therapy increases the risk of resistant viral strains. Thus, there is risk of recurrence of neuro-HIV disease also. Coming to the clinical spectrum of neuro-HIV disease, the complications are common, diverse, and are clinically significant. It occurs in 50% of HIV patients clinically and almost all patients at autopsy, that is, they had a subclinical disease. Primary HIV related manifestations which can be involve central nervous system or peripheral nervous system. Coming to central nervous system, disorders like HIV associated dementia, HIV associated neurocognitive disorders like mild cognitive disorders, involving spinal cord like myelopathy, vascular myelopathy, involving peripheral nervous system like distal sensory polyneuropathy, inflammatory neuropathies, involving muscle, very less commonly they may have myopathy. Opportunistic infections. Opportunistic CNS infections like cerebral toxoplasmosis, progressive multifocal leukoencephalopathy, cryptococcal meningitis, CMV encephalitis. Neoplasms like primary CNS lymphoma and treatment-related disorders like drug toxicity, ART side effects, immune reconstitution, inflammatory syndrome. Coming to aseptic HIV meningitis, you should know when it should be suspected. It can happen early in the phase of disease while seroconversion, or it can happen later in the stages of disease. Clinical features are headache, commonly, many signs of meningeal irritation with preserved cognition. CSF findings are mild lymphocytosis, mildly elevated proteins, normal glucose. Diagnosis is by excluding causes like tuberculosis, syphilis, and fungal infections. Prognosis is usually good, and there is no specific treatment required other than antiretroviral therapy. HIV associated neurocognitive disorders. It has been classified into three stages, that is, asymptomatic neurocognitive impairment, mild neurocognitive disorder, and most severe HIV associated dementia. These disorders are commonly have features like cognition, poor attention, slower thinking, memory issues, behavioral feature, apathy, social withdrawal, motor disturbance, gait disturbance, poor coordination, Parkinsonian features. Advanced stages of this will have mutism, incontinence, and bedbound state. Evaluation is by doing MRI. We can see diffuse cerebral atrophy and white matter changes. CSF may show mild non-specific changes. Neuropsychiatric testing helps in early detection. Management is by giving antiretroviral therapy. Patient usually will have a good improvement, and adherence to the antiretroviral therapy is important.
Coming to the next topic, AIDS dementia complex. HIV associated neurocognitive disorder in severe form presents as AIDS dementia complex. It's a chronic neurodegenerative condition seen in the AIDS. It is characterized by progressive cognitive decline, motor dysfunction, and diffuse brain atrophy. It occurs in 15 to 20% of the AIDS patients. Risk factors in the pathology. Pathologically, you may find grossly there is diffuse brain atrophy. Microscopically, there may be features suggestive of HFA encephalitis like multinucleated giant cells, microglial nodules, and myelin loss. Or they may have features suggestive of HIV leukoencephalopathy like diffuse demyelination, astrocytosis, macrophage infiltration. The risk factors are CD4 count less than 200, high CSF viral load, longer duration of HIV infection, and older age of seroconversion. The features are early symptoms like inattention, apathy, and psychomotor slowing, progresses to symptoms like memory impairment, motor dysfunction, and frank dementia. CT brain will show diffuse cerebral atrophy out of proportion for the age, and there can be symmetrical hypodensity in the periventricular white matter and deep white matter without mass effect or without contrast enhancement. MRI brain shows diffuse atrophy, symmetrical T1 and T2 white matter changes, predominantly in the periventricular deep white matter frontal lobe, and may also involve corpus callosum gene. There is no mass effect and there is no enhancement. If there is any, then think of alternative diagnosis like infection or tumor. MR spectroscopy shows reduced N-acetyl aspartate indicating neuronal loss, increased choline demyelination, increased myostatin gliosis. Advanced imaging like diffusion tensor imaging detects early white matter changes even if MRI is normal. Highly active antiretroviral therapy improves the survival significantly, reducing the incidence of new lesions. Imaging may initially worsen and later improves over time after starting ART. Pre-HAART median survival was 6 months after dementia onset. Post-HAART therapy, there is marked survival improvement that is 7 times more. More patients are living longer with AIDS dementia complex. In this image, we can see AIDS dementia complex in a 27-year-old man. Photograph of the gross specimen demonstrating that the sulci are prominent for the patient's age, consistent with a marked reduction in the brain volume. Second image shows photomicrograph showing a multinucleated giant cell, which is characteristic of HSV encephalitis. In these images, we can see AIDS dementia complex in a 36-year-old man with a progressive dementia. First image is a unenhanced axial CT image demonstrating prominence of the sulci and ventricles and findings consistent with the global volume loss. Symmetrical low attenuation is present at the periventricular white matter. In second image, we can see axial T2 weighted image demonstrating prominence of sulci and ventricles, finding consistent with diffuse atrophy. Symmetric periventricular hyperintensities correspond to the region of low attenuation seen on the CT image. There is no associated mass effect here. In the third image, The post contrast, that is contrast material enhanced T1 weighted image showing there is no enhancement or associated is associated with the region of T2 hyperintensity. Coming to the opportunistic infections, first one is the cryptococcal meningitis. It's caused by Cryptococcus neoformans, found in the soil contaminated with the bird droppings. Most common CNS infection this is. Pathology. If there is meningitis, thickened leptomeninges are seen. If there is pseudosis, soap bubble appearance of basal ganglia are seen. Sometimes cryptococcomas can be seen, like granulomas or gelatinous lesions. Special stains can be used like India ink stain and muscardine stain. Imaging features, often minimal or subtle findings. Common findings are hydrocephalus, most commonly, dilated ventricular spaces leading to cyst-like lesions. Key distinguishing points are no diffusion restriction, which helps in differentiating it from the pyogenic abscess. The differential diagnosis for these lesions are toxoplasmosis, CNS lymphoma, and pyogenic abscess. Treatment and prognosis. Diagnosis is via CSF cryptococcal antigen. It is the best test. India can be less sensitive at times. Treatment involves induction therapy using amphotericin B with or without flucytosine, maintenance therapy using fluconazole. Key complications are increased intracranial pressure. Mortality is 10 to 30% with the treatment and nearly 100% without the treatment. Here we can see cryptococcal meningoencephalitis in a 42-year-old man with AIDS who became progressively abtended. First image, photograph of a gross specimen of the basal ganglia demonstrating lesions that have a soap bubble appearance. Second image, photomicrograph depicting faintly staining yeast. Third photo, axial T2 weighted image showing multiple foci of high signal intensity within the bilateral basal ganglia, findings consistent with the gelatinous pseudocyst in the dilated periventricular spaces. Enlargement of the ventricles and which is consistent with the hydrocephalus is also present. Here we can see cryptococcal meningoencephalitis in a 42-year-old woman. First image, axial T2 weighted image demonstrating high signal intensity in the right occipital lobe. In addition, foci of the hyperintensity are present in the bilateral basal ganglia, findings consistent with the gelatinous pseudocyst. Second image, axial T1 weighted image demonstrating low signal intensity in the right occipital lobe that corresponds to the area of hyperintensity seen in the figure A. Third image, we see axial post-contrast T1 weighted image demonstrating leptomeningeal enhancement in the region of T2 hyperintensity. Here we can see cryptococoma in a 25-year-old HIV infected patient who presented with increasing headache, nausea and vomiting. First image is axial T1 weighted image demonstrating a low signal intensity mass lesion in the right cerebellum. Second image, on an axial T2 weighted image, the mass is heterogeneous in the signal intensity but predominantly hyperintense with the surrounding rim of T2 hyperintensity, a finding consistent with the edema. Third image, post-contrast T1 weighted image revealing peripheral nodular enhancement of the lesion. Coming to CMV encephalitis. CMV is a member of herpes virus group. It remains latent and reactivates upon immunosuppression. It occurs when CD4 count is less than 50 cells, clinically diagnosed in less than 2% of cases, but found in 10 to 40% of the autopsy cases. Incidence has reduced after starting HART. It presents as meningoencephalitis. Ventriculitis is the most characteristic, retinitis, and patterns are microglial nodular encephalitis or ventriculoencephalitis. Pathologically, there is eosinophilic intranuclear inclusions with a halo like Ohl's eye appearance. Imaging is often normal or non-specific. CT shows diffuse low attenuation in the white matter. MRI shows T2 hyperintensity in the white matter. Periventricular or subependymal signal changes. Ependymal enhancement like in CMV ventriculitis. Ependymitis or ventriculitis, that is ependymal and periventricular involvement. Rarely ring enhancing or mass-like lesions seen uncommonly. Differential diagnoses to be considered are bacterial ventriculitis, in which patient more acutely ill, and has severe systemic signs. Second one is CNS lymphoma, where patient has irregular nodular ependymal enhancement, often focal mass rather than diffuse pattern. Treatment involves ganciclovir with foscarnet. It helps in improving neurological status. Response to therapy is often temporary. It carries a poorer prognosis, CMV ventriculitis, death in days to weeks. Even with treatment, long-term recovery carries poor prognosis. Here we can see CMV ependymitis in a 30-year-old man with AIDS. First image shows coronal T2 weighted FLAIR image demonstrating circumferential hyperintensity surrounding the lateral and the fourth ventricle. Non-specific T2 signal is present in the white matter. In second image, we can see coronal post-contrast T1 weighted images revealing thin linear periventricular enhancement. The non-specific T2 hyperintensity in the white matter did not enhance. Coming to toxoplasmosis, it's caused by Toxoplasma gondii. It's an obligate intracellular protozoan. Here, oocysts from the cats infect the humans via ingestion. Tachyzoids will rapidly multiply, causing acute active infection. Bradyzoids will form latent tissue cyst in the CNS or the muscle. It is most common CNS mass lesion in AIDS patients. 15 to 50% of AIDS patients will have this disease. Reactivation of latent infection is very common. Risk increases when CD4 count is less than 100. Serology is positive if positive is not diagnostic because many are already exposed. But if it is negative, it doesn't rule out the disease also, especially when patient has AIDS. Pathologically, we can see necrotizing encephalitis. Key findings are numerous tachyzoids, bradyzoid cysts at the lesion periphery, occurring in common sites like basal ganglia, thalamus, corticomedullary junction, brainstem. Clinical features are due to mass effect and inflammation. They present as focal neurological deficit, seizures, and headache. CT scan shows multiple hypodense lesion, ring or nodular enhancing. MRI shows T2 to isointense lesion with the surrounding edema. Post-contrast study may show multiple ring enhancing lesions, sometimes eccentric target sign. Occasional hemorrhage helps in differentiating it from the lymphoma. Differential diagnosis are the main confusion is with the primary CNS lymphoma. The clues favoring the toxoplasmosis are multiple small lesions, basal ganglia involvement, and hemorrhage. Clues favoring the lymphoma are periventricular lesion, solitary lesion more common, and lesser hemorrhage. Advanced imaging is by SPECT or FDG-PET. Lymphoma shows is positive since it's a neoplasm and toxoplasma is negative. MR spectroscopy, we can see toxoplasmosis has increased lipid and lactate peak and lymphoma has increased choline peak. DWA images lymphoma may show restricted diffusion. Here we can see a 28-year-old man with the HIV infection. First image shows photograph of a gross specimen showing necrotic appearance of the mass lesion in the bilateral basal ganglia. Second image, photomicrograph demonstrating cyst that contains bradyzoid. Third image, axial T2 weighted image demonstrating a region involving right basal ganglia that is isointense to hypointense relative to the gray matter. The lesion is surrounded in the fourth image. The lesion is surrounded by high signal intensity vasogenic edema. Here we can see toxoplasmosis in a 31-year-old patient with AIDS who presented with headache and altered mental status. Coronal post-contrast T1 weighted image demonstrate ring-enhanced lesion with the eccentric nodules. The target sign. Mild linear dural enhancement was presumed to be from the recent lumbar puncture. Here we can see acute toxoplasmosis in a 37-year-old man with a previous history of toxoplasmosis who had discontinued his prophylactic therapy. First image, axial enhanced CT image revealing a peripherally calcified lesion in the right caudate head that is sequelae of previous toxoplasma infection. The low attenuation mass lesion with surrounding vasogenic edema in the region of left basal ganglia is from a new focus of toxoplasmosis. In second image, we can see axial flare image demonstrates Marked vasogenic edema that involves the region of the left basal ganglia and thalamus and the surrounds a region of low signal intensity. The low signal intensity secondary to calcification is seen around the lesion in the region of caudate head. The next topic is CNS tuberculosis. It is caused by Mycobacterium tuberculosis. It is strongly associated with HIV and AIDS. It is considered as AIDS defining illness also. It occurs due to reactivation of the latent infection in the body, or it can be due to primary infection. The spread to CNS happens via hematogenous route. Epidemiology, there is high mortality associated with CNS tuberculosis, like more than 70% cases in overall CNS TB. It occurs in 5 to 9% of AIDS patients, and 2 to 18% of them have CNS involvement. Chest X-ray is positive in 65% of the cases. Tubercular meningitis is the most common form. It predominantly affects the basal cistern around the circle of Willis. HIV patients will have reduced basal exudates and increased bacilli in the brain and meninges. Tuberculoma, here the granulomatous lesion is present with the central caseating necrosis and the surrounding cells like epithelioid cells and Langerhans giant cells. There are few bacilli present on smear. Other manifestations are tubercular abscess and cerebral infarction due to vascular involvement. Imaging features, general findings are hydrocephalus, meningeal enhancement due to obstruction of the basal cistern. In tuberculoma, early phases, there is due to hypointensity in the center, suggestive of caseation, and isointense capsule. Later, it may become hyperintense center due to abscess formation. Non-caseating lesions will have homogeneous enhancement, whereas caseating ones will have the ring enhancement. Tubercular abscess is more common in HIV when the size of the lesion is more than 3 centimeters, usually found as solitary lesion. MRI will show ring enhancement. Spectroscopy will show lipid and lactate peak with and no amino acid peak, unlike bacterial abscess. Infarction is seen in 36% of cases. It occurs due to vasospasm and thrombosis. Affects basal ganglia perforators most commonly. It is detected by DWA sequences. Differential diagnoses to be considered are toxoplasmosis and primary CNS lymphoma. Clues favoring tuberculosis are hydrocephalus, basal meningeal enhancement, basal ganglia infarcts. Treatment is anti-tubercular therapy with steroids, especially in case of meningitis. TB meningitis mortality is 30%. It can worsen in HIV patients. It is usually due to delayed diagnosis. Here we can see tuberculosis basilar meningitis in a 30-year-old woman with HIV infection. First image is a photograph of the gross specimen revealing thick purulent exudate, most predominantly in the basal cistern and anterior to the pons, a finding consistent with the meningitis. Second image shows unenhanced axial CT image with high attenuation material in the basal cistern. Third image, we can see axial post-contrast CT image revealing enhancement in the basal cistern. Here we can see tuberculoma in a 32-year-old man with a HIV infection who presented with headache. First image is axial T2 weighted image demonstrating small peripherally located low intensity lesion with the surrounding vasogenic edema. Second image axial post contrast T1 weighted image showing multiple small separate confluent avidly enhancing lesions. Third image we can see photograph of the resected gross specimen revealing a nodular mass. Coming to neurosyphilis, it's a sexually transmitted infection due to Treponema pallidum. The incidence increases in patient with HIV or AIDS. It can present at any stage of the syphilis. 1.5% of the AIDS patient are infected with this, whereas CNS involvement occurs in 5 to 15%, 5 to 10% of untreated cases. In HIV, they have a shorter latency and a more aggressive course. Clinical features are asymptomatic or non-specific, like headache, seizure, personality change, confusion. It presents as four clinical types. The first type is meningeal, early within 2 years, presents as acute meningitis, headache, rhinopathy, hydrocephalus. Second clinical type, meningovascular, 5 to 7 years, presents like headache, transient hemiparesis, stroke-like episodes. Third clinical type, generalized paresis. Fourth clinical type is types dorsalis. These two are rare due to treatment available currently. Diagnosis is via serum fluorescent antibody testing. CSF findings are pleocytosis, elevated proteins, and VDRL is highly specific if positive, but it can be negative in 50% of cases. Pathology, we may find out leptomeningitis, multifocal arteritis like small vessel endarteritis, large or medium vessel arteritis. It leads to cerebral infarction, hence the neurological deficit. The key feature here is gamma, which is a necrotic mass with preserved reticulin. Pathologically, there is fibrosis and necrosis. It involves inflammatory cells like lymphocytes and plasma cells. Spirochetes are usually absent in these lesions. Imaging features, we can find gamma in peripheral cortex. CT shows isodense to the cortex. MRI shows T1 isointense and T2 hyperintense. And there is enhancement with the contrast. This is how gamma presents on imaging. The general findings found in imaging are cerebral atrophy, white matter lesions, infarct with multiple ages, and leptomeningeal enhancement. The infarcts are common in basal ganglia perforator location, brainstem, middle cerebral artery territory. Always consider in HIV patient with stroke. Special point is mesiotemporal T2 hyperintensity will mimic the hypersimplex encephalitis. This is a point to be remembered. And cranial involvement usually involves optic nerve and vestibulocochlear nerve. Treatment is syphilis is highly treatable with antibiotics, the penicillin group. Early diagnosis is crucial to start the treatment. Prognosis, it has more aggressive course in case of HIV patient. Good outcome is present if treated early. Here we can see syphilitic gamma in a 32-year-old man with HIV infection under positive VDRL test. First image, axial T2 weighted image showing extraaxial, predominantly hyperintense lesion in the central focus of the low signal intensity. Second image, on a coronal post-contrast T1 weighted image, the lesion heterogeneously enhances and demonstrates a mild degree of dural enhancement. Coming to next topic, progressive multifocal leukoencephalopathy, a progressive demyelinating CNS disorder caused by John Cunningham virus. The mechanism involved is direct infection of the oligodendrocyte, thus failure of myelin production, hence demyelination. There is minimal inflammation involved. The JC virus infection usually occurs in childhood, but it remains latent for life. The reactivation occurs only in immunocompromised states, especially like AIDS. It is characterized by features like progressive focal deficits, vision loss, aphasia, and ataxia. It is seen in 5% of the AIDS autopsies, and there is high risk when CD4 count is 50 to 100 cells. Without treatment, the mortality is 90% within a year. MRI will show non-enhanced white matter lesions. Diagnosis is by CSF PCR for JC virus. Specificity is 96%. Sensitivity reduced after the heart therapy. Treatment, there is no specific treatment, and antiretroviral therapy usually helps in survival. Imaging features, grossly, there may be mild brain atrophy less than ADC and multifocal demyelination. Microscopically, there is enlarged oligodendrocyte with ground glass nuclei, bizarre astrocytes, there is minimal inflammation, and there is spaghetti and meatball appearance due to viral particles. CT scan shows asymmetrical hypodense lesion in the periventricular and subcortical white matter. Asymmetry is the key uh, because symmetry is seen in HIV dementia. MRI features, there is multifocal asymmetrical lesions which are T1 hypointense, T2 flare hyperintense. The typical location are subcortical white matter, periventricular regions, and U fiber involvement. The enhancement is important finding. It may show faint peripheral enhancement. Associated with these enhancement is associated with a better prognosis and a possible good immune response. Advanced imaging, diffusion weighted imaging, high signal intensity is present at the lesion edge, that is, representing an active demyelination zone. ADC sequences will show increased intensity at the center and reduced intensity at the periphery. Spectroscopy will show reduced NAA suggestive of neuronal loss and increased choline suggestive of demyelination and increased lipid and lactate also. Here we can see uh, PML in a 30-year-old man with the AIDS. The first image is a photograph of the specimen stained with the myelin stain. Shows an area without stain, finding consistent with the demyelination. Second photograph of a gross specimen demonstrates area of subcortical demyelination that appears to be grossly necrotic in some regions. Third image, coronal post-contrast T1 weighted image corresponding to the gross specimen in B. It shows low signal intensity involving the white matter of the left hemisphere, including subcortical U fibers. There is no enhancement seen here. Image 4, photomicrograph demonstrating enlarged oligodendroglial nuclei with a ground glass appearance that are characteristic of PML. Fifth image, electron microscope revealing viral particles with an oligodendrocyte nucleus that are both spherical and filamentous, the spaghetti and meatball appearance. Here, in this image, there is PML in a 30-year-old woman with HIV infection. First image, axial unenhanced CT revealing a focal area of low attenuation within the white matter of the right hemisphere. The subcortical U fibers are involved, and there is no mass effect is present. In second image, axial T2 weighted image depicting hyperintensity involving the white matter of the right hemisphere, including subcortical U fibers. There is no mass effect seen. In the third image, there is axial post-contrast T1 weighted image demonstrating hypointensity and no evidence of associated enhancement. In this picture, there is first image is a PML in a 30-year-old woman with HIV infection. The coronal post-contrast T1 weighted image showing patchy enhancement in the left temporal lobe. In second image, there is axial T1 weighted image demonstrating the area of low signal intensity involving the white matter of the right frontal lobe that crosses the corpus callosum to the white matter of the left frontal lobe with a mild mass effect present. Third image, axial post-contrast T1 weighted image demonstrating peripheral enhancement, which is more confluent than typically seen in patients with PML. A neoplastic process such as lymphoma or glioma would be the differential diagnosis, and at autopsy, the lesion proved out to be PML. In this image, here is the image of PML in a 28-year-old woman. There is diffusion weighted image demonstrating hyperintensity along the peripheral of the PML lesion that involves both the frontal lobes. Second image, ADC map demonstrating low signal intensity along the periphery and increased signal intensity centrally within the lesion.
Immune reconstitution inflammatory syndrome. It is paradoxical worsening after starting antiretroviral therapy due to immune recovery. It is classified as paradoxical iris due to known infection which will worsen, unmasked iris where hidden infection becomes apparent. It happens usually in neurological conditions like cryptococcal meningitis, CMV retinitis, progressive multifocal leukoencephalopathy. Iris occurs after starting antiretroviral therapy. It happens because of immune recovery where there is exaggerated inflammatory response. It usually happens first few months after starting ART. It is characterized by key features like paradoxical worsening despite increasing CD4 count and reduced viral load. Imaging can show increased enhancement and increased mass effect. In this image, we can see a patient of iris Biopsy proven PML showing axial T2 first image, axial T2 weighted flare image demonstrating T2 hyperintensity in bilateral periarterial white matter. Second image, axial post-contrast T1 weighted image revealing diffuse patchy enhancement in the region of T2 hyperintensity. Third image, axial T2 weighted flare image obtained 2 weeks after the demonstrate progression of the T2 hyperintensity with an increase in mass effect. Fourth image, axial post-contrast T1 weighted image reveals progression of patchy enhancement in the 2-week interval. The iris is managed by continuing ART. If the condition worsens or severity increases, corticosteroids are used. Primary CNS lymphoma, Epstein-Barr virus-associated B-cell lymphoma. It is characterized by focal neurological deficits, behavioral changes, and subacute progression. MRI shows deep lesions near the ventricles, which may be ring enhancing. Diagnosed by CSF, EBV, PCR, and brain biopsy, which is definitive. Treatment involves antiretroviral therapy, radiation, and steroids. This table shows us how to differentiate between toxoplasmosis, PML, and primary CNS lymphoma. Toxoplasmosis lesions are multiple, ring enhancing, edema is present. It is due to the parasite. PML lesions are diffuse, ring enhancement is absent, edema is minimal, caused by JC virus. Primary CNS lymphoma lesion is often single or multifocal, ring or irregularly enhancement present, edema is variable, cause is lymphoma. Fungal CNS infections. Common organisms are Candida, Cryptococcus neoformans, Aspergillus fumigatus. The incidence and mortality has increased significantly after the AIDS. Aspergillosis. It's caused by Aspergillus fumigatus. It is found usually in soil and decaying vegetations. It's an angio-invasive fungus. It spreads via hematogenous route from lungs and direct extension from the sinuses. Clinical features are stroke-like symptoms due to infarct, cranial nerve palsy if skull base is involved, visual disturbances, and sinonasal infection carries very high mortality. Key pathophysiology. The infection invades the blood vessel, leading to thrombosis, hemorrhage, infarction. It prefers perforating arteries. Pathology, we can see septate hyphae with acute angle branching. There are three patterns seen on imaging. 1. Diffuse lesion. Multiple cortical, subcortical T2 hyperintensity. 2. Ring enhancing lesion. Abscess-like appearance. 3. Dural with sinus involvement. Adjacent sinus is also infected. Key imaging clues. Hemorrhage in the lesion is a strong clue. It involves the basal ganglia, thalamus, corpus callosum. In diffusion weighted imaging, the wall will show restricted diffusion, core will show no restriction, unlike pyogenic abscess. Differential diagnoses are other fungal infections like mucormycosis, tubercular abscess, pyogenic abscess, tumors. Treatment and prognosis. It carries very high mortality, 88%. There is only limited effective treatment and prevention is critical. Here is the table differentiating between cryptococcosis and aspergillosis. Cryptococcosis occurs common site is basal ganglia. Key feature is soapable pseudocyst. Diffusion restriction is absent. Enhancement is minimal. Hydrocephalus is common. Mortality is moderate. Whereas in aspergillosis, the common site is MCA territory. Key feature is angioinvasion with hemorrhage. Diffusion restriction is mixed pattern. Enhancement is ring. Hydrocephalus is very rare. Mortality is very high. Here we can see disseminated aspergillosis in a 38-year-old man with HIV infection. First picture, photomicrograph revealing septate hyphae that branch at acute angles, an appearance consistent with the aspergillosis. Second photograph of the gross specimen demonstrating several abscesses and hemorrhagic foci. Third image, axial post-contrast CT image demonstrating multiple circumscribed regions of hypoattenuation with faint peripheral enhancement. Here we can see disseminated aspergillosis in a 39-year-old AIDS patient. Axial T2 weighted FLAIR image shows two well-circumscribed foci of hyperintensity within the centrum semi-oval. There is no significant surrounding edema. Second image, axial post-contrast T1 weighted image demonstrates low signal intensity lesion that do not demonstrate enhancement. Here we can see aspergillosis in a 36-year-old woman with HIV infection who experienced a rapid decline in consciousness. First image, axial unenhanced CT revealing large parenchymal hemorrhage involving the left hemisphere that caused mass effect and midline shift. Second image, gross specimen demonstrating the large area of hemorrhage. Vacuolar myelopathy. It's a chronic degenerative spinal cord disorder commonly seen in AIDS stage. It is characterized by vacuolation, that is microscopic hole formation in the white matter, especially posterior column and lateral corticospinal tract. Risk factors are advanced immunosuppression like CD4 count less than 100, long-standing untreated HIV, often associated with HIV-associated dementia. Pathophysiology, it doesn't occur due to direct HIV invasion alone. It is multifactorial in the form of cytokine-mediated injury, that is TNF-alpha neurotoxic factors. The second factor is macrophage activation within the spinal cord. Third factor is impaired myelin metabolism. All these factors leads to myelin damage and axonal degeneration. Clinical features are motor features like progressive spastic paraparesis, increased tone hyperreflexia, positive Babinski. Sensory features like loss of vibration, position sense, thus sensory ataxia. Gait in the form of stiff, slow, spastic gait. Difficulty in walking may progress to wheelchair. Bladder dysfunction in the form of urgency, incontinence, and retention. Histopathology shows vacuolation of the white matter, myelin pallor, predominantly the posterior column and the lateral column. Differential diagnoses are subacute combined degeneration, multiple sclerosis, HTLV-1 associated myelopathy, and spinal cord compression. MRI spine may be normal or may show spinal cord atrophy, T2 hyperintensity in the posterior or lateral column. CSF analysis usually non-specific with mildly elevated proteins. Blood test shows normal B12 levels. HIV markers are low CD4 count and high viral load. Management mainstay is antiretroviral therapy. It may halt the progression. It rarely reverses the deficit. Supportive care involves physiotherapy, baclofen, tizanidine for spasticity control, and bladder management. Prognosis, it is slowly progressive. Partial stabilization with ART is seen. Neurological deficits often are irreversible. Coming to stroke in HIV, the stroke in HIV can be due to vasculitis, coagulopathy, infections, and cardiac emboli. It has to be considered in young stroke patients. In this condition, multiple lesions can coexist, and not all neurosymptoms are due to HIV related. So, when CD4 count is 500 and above, we should think of autoimmune conditions. 200 to 500, think of primary HIV disease. Less than 200, we should consider opportunistic infections. HIV associated neuromuscular disorders. First is peripheral neuropathies, most commonly. Second, myopathies. Third, neuromuscular junction and rare syndromes. Coming to peripheral nerve involvement, seen in 15 to 25% cases clinically, nearly universally present in advanced AIDS stage. The classification, it can present in the form of distal sensory polyneuropathy, Drug-induced toxic neuropathy, AADP, CADP, CMV polyradiculomyelopathy, mononeuritis multiplex. Distal sensory polyneuropathy, it is the most common presentation. It occurs later in disease with reduced CD4 count. It presents in the form of symmetrical stopping distribution. Sensory symptoms are burning pain, numbness, paresthesias. Signs are reduced ankle reflexes and mild sensory loss. Hands are involved later in the disease. It involves cytokine-mediated toxicity and HIV effects on the dorsal root ganglion. Treatment involves antiretroviral therapy and pain control using gabapentin, pregabalin, duloxetine, and TCAs. Drug-induced toxic neuropathy. Older NRTIs are known to cause drug-induced neuropathies. They are didanosine, stavudine, zalcitabine. There is something called coasting phenomenon where symptom worsens temporarily after stopping the drug. Rapid onset neuropathy in HIV patient and who's taking NRTIs, we should think of drug toxicity. We should comparing drug-induced neuropathy with the distal sensory polyneuropathy. Distal sensory polyneuropathy onset is slower, cause is HIV virus, reversibility is limited. Drug-induced neuropathy onset is rapid, cause is drug-induced, reversibility improves after stopping the drug. AADP or CADP, it resembles Guillain-Barré syndrome. AADP features are rapidly ascending weakness, areflexia, possible respiratory failure. CADP features chronic relapsing course, CSF finding elevated protein and lymphocytic pleocytosis. Treatment is IVIG, plasmapheresis, and steroids. CMV polyradiculomyelopathy, it occurs in CD4 count less than 50, characterized by rapid cauda equina syndrome, that is leg weakness followed by paralysis, areflexia, bladder dysfunction. CSF shows increased cells and increased protein and reduced glucose. Diagnosis is by CMV PCR. Treatment involves IV ganciclovir with or without foscarnet, usually fatal if untreated. Mononeuritis multiplex, it's characterized by asymmetric nerve involvement, multiple nerves. Caused by early HIV infection, it is immune mediated, later it is CMV mediated. Treatment is early phase steroids and later phase antiviral. Myopathies. A. HIV-associated polymyositis. Character features are proximal muscle weakness and myalgia. Investigations: elevated creatinine kinase, EMG showing myopathic pattern, biopsy showing inflammation and fiber necrosis. Treatment is steroid, that is prednisone. Zidovudine myopathy causes mitochondrial toxicity. Features are proximal weakness, myalgia. Diagnostic clue is long-term zidovudine use. Biopsy shows mitochondrial changes, minimal inflammation. Treatment is stopping or reducing the drug dosage. Polymyositis causes are bacterial infection, usually Staphylococcus aureus. Presents as localized muscle pain and abscess. Treated with antibiotics and drainage if needed.